Imagine this. You have what feels like a warning stroke, a transient ischemic attack, or TIA. Maybe your vision gets blurry, or you feel this weird weakness on one side of your body, and then it just goes away. Poof. You feel like you dodged a bullet, but really, a clock has just started ticking. Because what happens next is a super high-stakes race against time to stop a much, much bigger stroke from happening. Let's break down how doctors win that race.
And this number right here, this is why it's a race. For patients who get that warning shot, getting the right treatment right away can slash the risk of a major disabling stroke by a whopping 80%. I mean, that is an absolutely life-changing number, but it has to happen fast.
You know, we really need to change how we think about a TIA or a minor stroke. It's not the end of the story, it's just the beginning. It's the body's loudest, most urgent alarm bell screaming that there's a much bigger problem that needs your attention right now.
And that problem is very often this: symptomatic carotid artery stenosis, or SCAS for short. This is what doctors call it when that dangerous narrowing in your brain's main arteries has just caused symptoms. The blockage isn't just sitting there quietly anymore, it's actively threatening your brain. This image shows us exactly what the doctors see. See that little pinch point? That's stenosis. It's like a major clog in the fuel line to your brain. This isn't some abstract concept. It's a physical, ticking time bomb that has to be diffused before it causes a total shutdown.
So how do you diffuse that bomb? Well, the very first step is to stabilize things with medicine, immediately. There is no let's wait and see in this situation. It's all about aggressive medical management to calm the storm and stop another event from happening in the next few hours or days.
This first response really rests on three crucial pillars. Think of it as a rapid-fire three-pronged attack. Stop clots from forming, slash the bad cholesterol, and very, very carefully manage blood pressure. So let's take a look at each one. First up, antiplatelet therapy. This is all about making your blood less sticky. See, that narrowed artery is rough and inflamed, which makes it the perfect place for a clot to form and just block everything up. Aspirin is given right away to stop that from happening. And the urgency is real. Some studies even show that adding a second drug, clopidogrel, within the first 24 hours can be even more effective. Next, you have to go after the plaque itself, and that means getting aggressive with lipid control, using statins. The goal here is incredibly strict. Get that LDL, the so-called bad cholesterol, to below 70 milligrams per deciliter. This isn't just about long-term health, it's about stabilizing that dangerous plaque right now to stop a piece from breaking off and causing a stroke. And finally, there's blood pressure. And this is where things get a little tricky. You might think, okay, let's just drop it as fast as possible. But it's actually a really delicate balancing act. The key is that it has to be lowered gradually. If you drop it too fast, when an artery is already severely blocked, you can actually reduce the force that's pushing blood through that tiny opening and end up starving the brain of oxygen. It's a very carefully controlled descent. Okay, so the patient is stabilized on all this medication. But here's the thing. That's just step one. For most people with significant SCAS, the medicine is just buying time. The underlying mechanical problem, that clog in the artery, it still needs to be fixed.
And this quote from the source material really says it all. If you've had symptoms and your artery is more than 50% blocked, medicine by itself is almost never enough. The standard of care demands a direct intervention. And that brings us to the two main procedures, carotid endarterectomy, or CEA, and carotid artery stenting, or CAS.
And we know for a fact these interventions work. Landmark studies have shown that for patients with really severe stenosis, a procedure like an endarterectomy gives you an absolute risk reduction for stroke of about 15.3% over 5 years. That's compared to just taking medication. I mean, that is a massive, proven benefit. Okay, so the patient needs something done. But which one? This is what we call the doctor's dilemma. Do you go in and surgically remove the plaque, or do you use a less invasive method to prop the artery open with a stent? Let's dig into how doctors make that crucial decision. So here's the fundamental difference. CAS is kind of the classic plumber's approach. It's an open surgery where the surgeon physically goes in, opens the artery up, and literally scrapes the plaque out. CAS, on the other hand, is less invasive. A catheter is guided up through an artery, and a tiny little mesh tube, a stent, is deployed to basically push the plaque against the wall and prop the artery open from the inside.
So which one is safer? Well, it kind of depends on when you ask. The famous CREST study looked at the immediate 30-day risk, and the results from this chart are pretty clear. The open surgery, CEA, actually had a lower immediate risk of causing a stroke during the procedure itself compared to putting in a stent.
But, and this is a big but, if you look past that initial 30-day window and zoom out to 4 or 5 years, the picture totally changes. The long-term data shows that both procedures are remarkably similar in their ability to prevent major strokes. So that early advantage for surgery, it seems to even out over time.
So if they're both effective in the long run, how on earth do doctors choose? Well, they personalize the decision. They match the procedure to the patient. This table shows you some of the key factors. CEA, the open surgery, is often favored for older patients or if the symptoms are super recent. But stenting becomes the go-to choice if the patient has, say, severe heart or lung disease that makes open surgery too risky, or if they've had surgery on that artery before. It's all about matching the right tool to the right person.
You know, when you step back and look at the whole journey, from that first warning sign all the way to the final intervention, it's really a masterpiece of urgent, logical, and literally life-saving medicine.
All right, so let's recap the crucial points. First, a TIA is not a mini stroke you can just brush off. It is a full-blown medical emergency. Second, that immediate three-pronged medical therapy we talked about is the absolutely essential first step. Third, for most patients with symptoms, medicine isn't enough. Clearing the blockage with a procedure is the standard of care. And finally, the choice between surgery and stenting isn't about one being better, it's about which one is better for that specific individual patient.
And this brings us to the final, most critical thought. We have these incredibly effective tools to prevent a devastating stroke after a warning has been given. And what that means is that the single greatest risk isn't the blockage itself, but the chance that someone might ignore that first warning sign. So if there's one thing to remember from all of this, it's this. A warning stroke isn't a dodge bullet, it's a call to action. And taking immediate action saves lives.